Welcome to The Explainer. Today, we're unpacking a truly high-stakes medical puzzle regarding the female reproductive system. We're going to be looking at a groundbreaking anatomical concept that completely flips our traditional understanding of obstetric emergencies right on its head. If you've ever wondered how modern medicine could possibly still harbor hidden, life-saving secrets in human anatomy, well, you are definitely in the right place.
So why do standard treatments for severe postpartum hemorrhage sometimes mysteriously fail? We're talking about incredibly tense situations where experienced surgeons and interventional radiologists do exactly what the textbooks say, performing uterine artery embolizations or even full hysterectomies, and yet, inexplicably, the bleeding just continues. It's a literal life-or-death mystery where our standard interventions are just falling short.
To really grasp the gravity of this, we have to recognize the current landscape. Severe postpartum hemorrhage, combined with rising rates of adherent placentas, which is where the placenta grows way too deeply into the uterine wall, is actually driving up maternal mortality rates in several countries right now. So this isn't just some theoretical academic puzzle. Understanding the root cause of these intervention failures is absolutely crucial. It is directly about saving mothers' lives in the delivery room.
Section 1. The S1 and S2 segments. Defining the geography.
Okay, let's dive into this. The concept of the S1 and S2 segments was first defined back in 2005 by Dr. Palacios Giacomotta, and it completely changes our understanding of pelvic anatomy. By drawing a simple, imaginary line perpendicular to the posterior wall of the bladder on a side profile view, we can distinguish two completely separate blood supplies to the female reproductive system. This single invisible line totally redefines how medical professionals need to look at the region. It breaks it down into two distinct zones with very, very different vascular rules. Let's contrast these two segments directly. The S1 segment is basically the body of the uterus. Its blood supply is relatively straightforward. It's fed primarily by the ascending branches of the uterine artery and, to a lesser extent, the descending ovarian arteries. Pretty simple, right? But then look at S2. S2 corresponds to the lower uterine segment, the cervix, and the upper vagina, and its blood supply is incredibly complex. It's fed by this deep subperitoneal web, basically an interconnected network beneath the abdominal lining made up of the uterine, cervical, upper vesical, vaginal, and pudendal arteries. It's a highly complex, multi-vessel system, and as you'll see in a minute, that complexity is exactly where the danger lies.
Section 2. The hidden vascular network. A forgotten 18th century clue. The authors of our source material point out something really profound here. Quote, "Students of history are well aware that if one does not learn from the mistakes of the past, one is bound to repeat them." End quote. It turns out 18th century dissections hold the exact clues we need to solve our 21st century medical dilemmas. We've actually known the answer for a long, long time, but somehow we just stopped paying attention.
Get this. In 1833, a French anatomist named Bergerie correctly illustrated something fascinating. He depicted the true, massive size of the vaginal artery. But if you open a modern medical textbook today, the common perception taught to physicians is that the uterine artery is always the thickest and most dominant vessel. Well, we are about to bust that myth wide open, because this historical oversight has completely skewed our modern approach to obstetric bleeding.
And this brilliantly illustrates the reality. Recent cadaver studies involving 39 dissections confirm exactly what Bergerie saw almost 200 years ago. The main vaginal artery is actually larger, averaging 1.88 millimeters in diameter, compared to the uterine artery's 1.81. In fact, the inferior vaginal artery can be up to 33% thicker than the uterine artery. What this means is that the S2 segment is receiving a massive, dominant blood supply that operates entirely independently of the main uterine artery.
So now we need to talk about anastomosis. Think of anastomosis as this highly interconnected cross-wiring between different arterial systems. The female pelvis essentially operates like a dual-grid electrical system. You have the S1 grid and the S2 grid. If you shut down power, or in this case blood flow, to one grid, the blood doesn't just stop. It backfeeds through these microscopic anastomotic channels to keep the tissue alive.
Now, what's really interesting here is exactly where this backup blood is coming from in the lower pedicle. While the uterine artery chips in just 18% of the flow, a staggering 71% of the blood supply to the lower vaginal artery comes directly from the internal pudendal artery. This pudendal connection is the hidden powerhouse feeding the lower reproductive tract. It's basically a massive alternate power source that standard procedures completely overlook.
Section 3. Why standard interventions fail. The backdoor of bleeding.
So let's look at two very common failure scenarios. First, imagine a patient with severe postpartum hemorrhage. The radiologist embolizes the uterine artery to stop the bleeding, but it fails. Why? because the S2 segment just kicks in, backfeeding blood through those internal pudendal cross-anastomoses we just talked about. Second scenario, there's a deep vaginal tear from an instrumental delivery. The clinician performs a hysterectomy to save the patient. It fails. Why? Because a hysterectomy mainly targets the S1 segment, but the bleeding originates in S2. By removing the S1 segment, you are literally leaving the S2 backdoor wide open, and the hemorrhage just continues unabated.
And this whole dual grid backfeeding situation gets supercharged in cases of abnormal placentation, which is when the placenta attaches improperly to the uterine wall. Now, normally these cross connections are microscopic, but when an abnormally attached placenta releases vascular growth factors, the lower uterus stretches and thins out. These normally tiny connections become grossly enlarged, engorged, and highly visible. They basically turn into high-flow, low-resistance reservoirs, pumping blood straight into the S2 segment.
Misunderstanding this cross-wiring carries absolutely devastating risks. If an interventional radiologist tries to stop the bleeding by injecting small particles under high pressure into the uterine artery, those particles can easily bypass their intended target. They travel through these newly enlarged microscopic connections, right into the vesical arteries, the ones feeding the bladder. The tragic result here? Severe necrotic damage, meaning tissue death to the mother's bladder. The stakes seriously could not be higher.
Section 4. Strategies for saving lives. Mapping the intervention.
So the crucial point is this: you absolutely have to match the solution to the segment. If you're dealing with abnormal placentation in the S1 segment, the upper body of the uterus, a subtotal hysterectomy is an entirely appropriate and effective therapy. But if that abnormal placenta is in the S2 segment, attempting an immediate hysterectomy will slice right into that highly engorged pudendal network we discovered earlier. Doing so will precipitate a catastrophic, life-threatening hemorrhage. Treating an S2 problem with an S1 solution can literally be fatal.
So what is the safe surgical approach for S2? Well, the authors lay out a very specific protocol. First, you bypass the S2 segment entirely. You safely deliver the baby through a fundal incision way up high in the S1 segment. Then, you absolutely do not attempt to detach the placenta. You leave the placenta in situ, meaning exactly where it is. You cut the umbilical cord short, and you simply close the fundus. By doing this, you avoid triggering that massive S2 anastomotic bleeding network altogether.
Let's move on and see how this builds a clear, strategic action plan for clinicians once that immediate danger is stabilized, with the placenta left in place. They have 3 solid options. 1. Observe the patient closely in a high-dependency environment, keeping an eye out for infection or coagulation issues. 2. Safely transfer the patient to a tertiary care center where a planned hysterectomy can be performed by a fully equipped multidisciplinary team. Or 3. Consider embolization, either to handle intermittent hemorrhage or as a prep step before a planned surgery down the line.
Because this anatomy is just so tricky, subperitoneal, and highly variable from patient to patient, continuous hands-on learning is absolutely crucial. The source explicitly emphasizes that general obstetricians who perform instrumental deliveries really must master this S2 anatomy. And how do they do that? By attending fresh cadaver dissection courses and regularly studying surgical dissection videos. It really is the only way to truly understand the spatial relationships, safely navigate this hidden, highly vascular space, and carefully dissect crucial structures like the ureters without causing catastrophic harm.
We've seen today how a simple drawing from 1833 held the key to understanding a modern obstetric crisis. By redefining the uterus into S1 and S2 segments, we can finally decode why certain treatments fail and learn how to actually stop life-threatening hemorrhages. But this leaves us with a truly fascinating question to ponder. If a fact as vital as the massive size of the vaginal artery was lost to textbooks for over a century, how many other forgotten 18th century anatomical discoveries are just waiting out there to revolutionize modern medicine? Thank you so much for joining me in this explainer, and keep questioning what you know.